Hello, good evening, good afternoon, good morning, good day. Welcome to the Black Belt Academy of Surgical Skills. My name is David Wigan. I'm a professor in the Medical Education Research and Development Unit at the Faculty of Medicine at the University of Malaya. We're coming to you live from Kuala Lumpur this evening, and Dr. Apajita is in New Delhi, is on the production. I'm joined by my faithful audience, Dr. John Rudd, who's watched us almost from the beginning, and a fellow sensei, Prof. Sile, who will join us at the end of our conversation presentation. If this is your first time joining the Black Belt Academy, welcome and thank you very much. And if you are returning, thank you as well. We are accredited by the Royal College of Surgeons of Edinburgh. These sessions carry CPD points and certificates, and if you're here for the duration of this presentation, you will get your certificate, accredited by the college and the Academy of Medicine of Malaysia. We have to date talked about many aspects of suturing. And before I go on, please ask, could you turn your cameras off? Because when your camera is on, I'm reduced to a postage stamp on the side of my computer screen, which is 2 arms lengths away, and I will need to be able to see the screen to focus. It is your session, and I welcome questions and observations. Please put them in the chat, or if it's really pressing, you're welcome to ask questions as we go along, and I'll try to answer them for you. We started off with the fundamentals of stitching. It's how you stand and present at the table, remembering that 92% of surgeons end up with musculoskeletal degeneration because they don't stand properly. To be able to stand without your chin moving in the midline, from your head to ear, shoulder, hips, knees, and ankles. Remember, don't block them. Knees out. That the arm and functional anatomy, we have now published on this, is dependent on your shoulders being down and your elbows by the side, because when your elbows leave the side, the scapula is supported by 17 muscles on each side to hold that abduction. We described that the rotation of the arm is from the glenohumeral joint, but we're not using that movement, but more particularly the pronation, supination, and if you look at the anatomy of the head of the radius, it is round. Our needles are round, and they need to be carried through the tissues on the circle. We have explained that the principles of mathematics and geometry mean that the needle needs to be aligned properly. That is 90 degrees, being the perfect angle, and that is an angle that we will all easily recognize as exact or not exact. The needle has to be 90 degrees to the tissue, most of the occasions, 90 degrees across what you want to stitch, and 90 degrees into what you want to stitch, because the tissues, a bit like the what's weft of fabric, and if I hold that up, you can see the what's weft, your needle will only go through those gaps and not at an angle, a bit like the Chinese diving team hitting the water with no splash. And it's that no splash that is important and why we have introduced these low fidelity models in the Black Belt Academy, because they offer the same haptics as tissue and are more difficult. Indeed, we've put the banana through a CT scanner and compared that with the Hounsfield units of these plastic suture pads that we see. The banana has been described by a colleague as a fun but punishing model that gives you immediate feedback. And I've seen students within 5 weeks learning the principles of alignment of the needle. We've done this in 2 dimensions, on a linear incision, and then we changed it from a linear incision to an elliptical incision, where you recognize that the vector through the tissue at 90 degrees that side is different to the vector 90 degrees on the other side, subtending an angle of about 85, 90 degrees. And therefore, to get your stitch through one side and the other, you realize that you have to now change your body posture. We concluded last week, therefore, when you're going round, you're moving from one side to another, either deliberately stepping or simply shifting your weight, which tilts the pelvis and tilts the shoulders and helps you with the angles. Last week, we actually looked at then putting a patch on the banana. Not only do we have to think about the vectors now in one plane, we now have to think about it in the second plane. Which brings us to the final part of our stitching series for the moment, the anastomosis. Now, the anastomosis is a medical Latin term derived from Greek anastomosis, meaning outlet or opening. It has ana, up, on, or upon, a stoma, or mouth. So to furnish with a mouth is the anastomosis. And thus, the stom syllable is conjugate with that of stoma in botany and stoma in medicine. And anastomosis is the connection of two normally divergent structures. And it refers to the connection of blood vessels and of tubular structures like the bowel, the ureter, and Prof. Seeley will join us later, she's an expert on fallopian tubes. Our first part of this evening will be focusing on the bowel. But before we go there, just to remind you of a couple of things. And I'm also excited to tell you that the Black Belt Academy now has its own set of instruments. And these are going to be available in Malaysia to those people who are going to be joining our face-to-face academy. It comes with a lovely DeBakey forceps. Note, it has actually got our logo on the top, a rider needle holder, Macindosh scissors, and with inside the pack as well, we have a blade holder and a halstead. What's interesting that Sensei Caddy and I have noticed that the quality of instruments that people are buying are very cheap, but their ergonomics and feel of them is poor. And as we have explained in the beginning, your surgical instruments need to be an extension of your fingers, and you need to be able to feel the tissues by feeling the instrument. The principle being that you maximize the surface area of the palp of the fingers with your instrument in use. We also covered thinking about a circle and positioning ourselves within a circle and thinking of orientation as you would see on a clock. And I wonder if this is now difficult because most of us have actually got digital watches, and certainly in the UK, we don't wear watches on the wall. Indeed, it is frowned upon. But if I think I'm at 6 o'clock, opposite is 12, 3, and 9, and then 12 radial sutures of it in a smaller lumen, it is the same. But you're just looking at same spacing, but a narrow gauge. When we come to joining two, now I want to join that to that, but we've got to think of it as an isomer. 3 becomes 9, and 3 becomes 9, and we fold them together, as you see there. 6 to 6, 12 to 12, and 3 and 9s are joined. And that's how we think about our spacing and our orientation around the tube that we join together. We start furthest away, deep, but as I'll demonstrate this evening, in bowel anastomosis and in vascular anastomosis, there are a few tricks to help you mitigate the fact that this is round. In real terms, as we are looking at, I'm at 6 o'clock here, 12 o'clock, 3 o'clock, 9 o'clock, but at each and every position, you will see that our needle needs to go at 90 degrees to the tissue. Sometimes the 90 degrees is in that plane because of the orientation of the needle and the tissue itself. But whether it's in that plane or that plane, it's still 90 degrees to the tissue. Okay? And we need to appreciate that when operating at depth. When joining one tube to another, again, we look at it 12 to 12, 9 to 3, 3 to 9, and 6 to 6. And if we look through the tube at the bottom, we start furthest away from us because the principal is stitching towards us, to the posterior wall, and towards us over the anterior wall. That orientation and presentation is vitally important. So bowel anastomosis, or the art of bowel anastomosis, dates back to the 19th century. And Nicholas Sen's review, performed in 1893, detected approximately 60 different techniques for interstitial suture, which he attributed to ancient and modern methods, and found another 33 methods. And what's interesting, looking through the literature, as you'll see later, there are many different methods, but underneath them all, they're fundamental principles. So within the past 200 years, gastrointestinal anastomosis has been transformed from a life-threatening venture into a safe and relatively routine procedure. Suffice to say that when there is a leak, the consequences are catastrophic, with the mortality increasing from 4% up to 20%. And the reason why this has happened is because of our increased knowledge of the anatomy of the bowel, but the importance of the serosa of the bowel, and the fact that most of the collagen content in this place is in the submucosa. And we also have to remember that a continuous suture over this, if too tight, is a strangulation suture, which defeats the object, because for any anastomosis to heal in the bowel, it's got to be without tension and has to have a good blood supply. So your knowledge of the anatomy of the superior mesenteric artery and the inferior mesenteric artery and the watershed areas between the foregut, midgut, and hindgut of vital importance. But it was the knowledge of this and the importance of serosa being opposed. It was described by Antoine Lambert. And of course, you've heard it throughout all the talk so far, sterility with Lord Joseph Lister. So there are a number of things that can influence the choice of anastomosis technique, like the diameter of the bowel ends, contamination, accessibility, site of the anastomosis, hemodynamic conditions, availability of time, special equipment, notwithstanding the nutritional status of the patient, body habitus, and cardiorespiratory fitness. But Lambert proposed the construction of an intestinal anastomosis in 1826, describing a double layer of mucosa inverting technique using a suture of bites about 5 millimeter distance from the edge and about 1 centimeter apart. And this was reinforced by a serosal stitch of interrupted sutures as well. By the time of 1887, Halsted stated the basis for a safe anastomosis, as we have said all the way along, is gentle handling of the tissues, meticulous hemostasis, and that's not fulguration with the diathermy, energy transfer, etc., and barbecuing tissues, preservation of blood supply, strict aseptic technique, minimum tension on the tissues, accurate tissue apposition, and obliteration of dead space. And that dead space is your suture going through, cleaning on a rotation, because as I've demonstrated before, if you drag it in, drag it out, that green area will be submucosal abscess, and predisposed to dehiscence. So the principles have remained the same ever since, leaving us really to choose on technique, which is dependent on surgical experience and personal preference. And I did put in the chat a good summary of the evidence for what technique to use when. What's interesting, there is little difference between absorbable and non-absorbable. I was taught when I started general surgery in 1987, a bowel anastomosis was a two-layer cell, continuous layer through all of them using a absorbable catgut. Now it would be a monochrome, and an outer layer of interrupted silk sutures, which now be probably vicral. But there have been no randomized trials that have addressed this question of whether it's interrupted or continuous, and there's been no demonstration of one technique over another. A meta-analysis of 2006 of 670 patients concluded that there's no evidence that a two-layered technique yielded a lower post-operative leakage than a single layer. So now we've got a confusion because it's either interrupted or continuous, single or two-layer, end-to-end, side-to-side, or any combination, various suture materials, extramucosal, through the mucosal, or full-thickness sutures. And then it depends on the size and spacing of each suture. But just as when we thought this was now become complicated, rationalized, and totally irrational, we brought in something else. And this was the staples. And I remember back in 1988 in general surgery, and 1989 and 90, staples being introduced, and as trainees, we were introduced to what I call clump-click surgery. Now, whether these staples are oversewn, buried, or not, whether they're done end-to-end, side-to-side, different. But a stapled end side-to-side anastomosis is recommended following a right hemicolectomy, particularly if this operation is performed for adenocarcinoma. Another randomized trial showed anastomotic leaks equivalent between stapled and sutured. And 7 randomized and non-randomized studies have shown reduced anastomotic leak and reduced overall risk of complications from stapled anastomosis. So what is the evidence? Well, side-to-side ileocolic anastomosis in Crohn's disease suggests that suturing and stapling are equivalent. That's small bowel to small bowel. That is, as you know, got a better vascular supply. Colorectal authors concluded that there's no demonstrable difference or superiority of one technique over the other, regardless of the level of anastomosis, and said it was down to surgeon's judgment. Another of small bowel and large bowel anastomosis, some were stapled and some were hands sewn. The leak rate was significantly higher in the stapled group. So I don't think this answer has been sorted out. Suffice to say that I think the staples require the same meticulous attention to the positioning of them and attention to no tension and ensuring that the edges are bleeding. And that's where knowledge of the foregut, midgut, hindgut, and watershed areas are important. It does make it very difficult. Suffice to say, as I said, the mortality increases 4 to 5-fold if there's a leak. And that's where there can be a significant improvement in surgery. I believe it's all down to technique. And I've often used the metaphor, staple or not non-staple. If you had all the money in the world and you were going to purchase a designer suit or dress, would you go and buy it off the peg, machine cut? Or would you go to one of these really skilled tailors in Hong Kong, here in Malaysia, or in the Far East, or even Savile Row in London, and get a bespoke suit made for you? I'd quite like to have a bespoke suit made for me. Now, yes, there's a time issue in this, and there's an access issue in this. But good serving and good technique means that it's deliberate and slow, but effective and purposeful, as described by Lord Berkeley Monaghan. So I'm going to ask my assistant to join me as we're going to demonstrate our first model this evening. And I hope you like this model. It amused me, and I'm going to take you over the top so you can see it. So what I'm representing here is I've got a couple of baby socks, okay, held down with an elastic band, and I've got a red one on the outside indicating the serosa, a pink one on the inside indicating the mucosa. Okay, this side, I've tried to demonstrate to you that I've got mesentery. And when selecting the mesentery, the yellow lines here indicate that I've preserved the vascular supply. So, one easy way of starting this up is to put a mesenteric suture in this side and an anti-mesenteric suture in that side. And you'll see as I pull that together, that's taking that anastomosis and bringing it together. So I'm going to start stitching this, and we'll demonstrate. We're going to go from one side to the other. My assistant is leaning over my son's leaning over the kitchen island. It's a little bit awkward, but he's tall with long arms. So hopefully it's not going to be too much of a strain on his back. The important thing is a lateral hold and not a pull. Now, these are the instruments we've got. I've got DeBakey's non-tooth forceps, and gosh, do they feel nice. So I'm going to start on this side. I'm going to go through the mucosa. I'm going to pick up the submucosa, but I'm not going to go all the way through the submucosa. I'm going to get a bite of that. And similarly on this side, just get a submucosa, and sometimes you're going to have to do it in two. Mindful as you're manipulating bowel, as we said before, the pinching of the forceps is going to cause damage to the tissues. So I'm just going to, just give me a moment, I'm going to tie that. We will have a knot tying session later on. And remember, to join us for that. So I'm going to take it from this side. I'm going to try and invert this. And there are a number of mechanisms of doing it. So the advantage of the sock as well is it is also, get you in the picture, increase the light a little bit. It's thinking about my alignment. Now the alignment, the sock has got a beautiful rib in it. So I can see the rib, and therefore I can align my suture to the ribs of the sock. And I'm deliberately picking up submucosa, but not full thickness. Now this is, people do a number of different ways of stitching, and we'll demonstrate a couple of these. To hold the stitch. And I'm using this as a model to show that you've got multiple layers now, as well as the 3 dimensions. And I'm going to take it through here. Don't pull it tight, because what I'm going to do, there we go, I'm using a Vicryl here, and I'm not sure it's sliding through the tissue as well as it ought. So I'm going to think about my spacing. I'm going to go 5 ribs from there. I'm going to take it through. And I'm going to take this through, my suture through, once it's on the inside. And simply by pulling the suture through on the inside, I hope that I'm going to automatically start inverting this anastomosis because I'm taking up the tension from the inside. As we come onto the vascular anastomosis in a moment, you will see that I'm going to take up the tension when my suture is on the outside, and that will naturally evert rather than me inverting the present. So I'm conscious of lining my needle up, maintaining the spacing. I am actually deliberately picking up the submucosa tissue. I'm not going full thickness through the mucosa. And I'm going to pull it through. You can see now that that is starting to invert. I should not see any mucosa or light pink sock at all in this anastomosis. And at every stage, the principles of place is enabling you to space the sutures, and point is enabling you to precisely put your suture in a particular position. We'll look at this from the other side in a moment, and I hope that you can see I'm not expecting to see from the inside any sutures at all. Place, point, I'll pick up the submucosa because that's where the collagen is. Pick it up gently that side. There's almost a tacking suture, and then I'm coming through full thickness. And this would be considered a single layer closure. Originally, I was doing a continuous suture with a absorbable catgut through all the layers, and then supported with interrupted serosa-only stitches. The idea behind just picking up the subserosa is the mucosa itself is part of a watershed area and blood supply, and you don't want your suture to be strangulating more mucosa as you are bringing it together. And tension, as somebody said, how tight do we actually tie these? Well, it's a bit like Goldilocks. Not too tight, but not loose. And it's effectively tissue apposition, which you will appreciate if you holding the instrument slightly and rotating the needle cleanly through the tissue. I've just come to the end because I want to demonstrate the other little technique of why I've got a mucosal and a mesenteric and anti-mesenteric stitch in a second. And because the bowel is mobile in this place, we can use that to effect and literally rotate it on its axis. Now, as you look at the model, my elastic bands either side are represented by soft bowel clamps because you don't want any material in the bowel to actually contaminate the area at all. So what a lot of surgeons would do is obviously bowel prep is vitally important to ensure the bowel is clean. But even if it's clean, it's still potentially contaminated, and there will be enteric material within the bowel. So putting bowel clamps on that are softly applied to prevent any spillage, but many surgeons would wrap the area within a separate sterile drape to prevent any spillage or contamination at all. So I'm almost there. I'm going to take it through to the inside and just pick it up there. And I'm trying to invert this. And this is the strength stitch as well as preserving the mucosa. Now, when I come to the other side, I'll demonstrate the Cushing and Cornell stitches, which basically are inverting stitches. The one is going full thickness through the mucosa, and the other is doing what I'm doing, is picking up the submucosa in the stitch. So at this point, there's my mesenteric and anti-mesenteric stitch. I can push this through this side, pick it up, and literally turn the bowel on its axis like that, and turn it upside down. There you go. And now I'm on the other surface. So let's see how we did from the inside, shall we? Ooh, can we look at that more closely? Okay, and that's what I wanted to see. Okay, if you look at that, you've got two edges of the mucosa joined together there, all right? And it is inverting. I can now continue my suture down this side, but for convenience, I'm going to rotate it round towards me because I've got to always stitch towards me, remember? So I'm going to take my needle through this side and continue stitching towards me. So that's the advantage of turning it over. I now can continue towards me this side, and I can probably take that up the way, but that has given me stability. So the Cornell and Cushing sutures, to complete our description, and you've probably heard of them, are basically horizontal mattress sutures. And the horizontal mattress sutures that are designed to invert. So again, 5 millimeters from the edge. And I'm sorry, please point out when the camera is out of view because I'm concentrating on the model. And okay, there you go. So the horizontal mattress suture, Cornell and Cushing's. Here we go. It's 5 millimeters from the edge. And I'm also going to pick up a little bit of the submucosa as I do that and come out. Okay. And then I take it through there. I'm going to come, guess what? Equal and opposite the other side. And again, 5 millimeters from the edge. Take submucosa and there. I'll do it again because then you can see that this is now inverting. As well. See that? It's starting to invert there. So this is the Cornell or Cushing stitch, which is a horizontal mattress suture. One is actually going through the mucosa, complete, all the full thickness. The others on the submucosa. But I think the principles are the same. Is the submucosa is the area that is actually where the strength of the anastomosis is. I want to go on to the vascular anastomosis, but I'm going to point out one thing. When we do a bowel anastomosis, there's often a piece of mesentery. As you see, the yellow lines here representing a good blood supply, and you're looking at the arcades. But you've got this division in the mesentery. It's important to tag the peritoneum together because that is a source for an internal herniation. So you do need to close that. I'll take my mesentery off. It's a bit of a kitchen towel, very useful. And I'm going to convert my model now from a vascular model. I'm going to use old scissors, not new scissors, to cut the suture out. For those purists, you should not use scissors to actually cut suture material if it's of a certain thickness. It actually damages the instrument. But I'm actually quite pleased with the mucosal junction there and our inversion of the bowel. And that's what it's all about. So the bowel is inverting, and you need to consider preserving the blood supply, particularly of the mucosa. And therefore, your sutures have got to gently oppose and not strangulate, because it certainly would cause a serious problem. So converting this now to my vascular anastomosis. And in a vascular anastomosis, we commonly use proline because it glides through the tissues. So I'll fix the two socks together. I like this idea of baby socks. And now the thing is, just imagine that that is a dissection. And what happens in a dissection, you get a split between the intima media and the serosa. And literally, dissections can look like that. We'll come on to that in a moment, but I just want to talk you through a little bit about the history of the vascular anastomosis. So really, this started back in 1761, and a letter to Dr. William Hunter by Richard Lambert in Newcastle upon Tyne reported a successful repair of a small tear in a brachial artery by approximating the wound edges with a small steel pin. His results, however, could not be replicated, and the attempts at vascular anastomosis were shelved for a very long time. When people were presented with a bleed, basically the only treatment was ligation. But the understanding of the vessel physiology and thrombosis at the time was quite primitive. In 1889, Alexander Jasinowski theorized that one day it would be possible to repair vascular injuries. And 2 years later, he reported on 26 cases of arterial repairs of varying sizes in animals. In 1897, Murphy in the United States utilized the current medical understanding at the time of aseptic technique, thanks Lister, and vessel physiology to build a preliminary success of his technique and a framework for blood vessel anastomosis. He emphasized likewise the importance of infection, desiccation and drying out of the tissues, as well as accurate vessel wall approximation to prevent thrombosis. However, Murphy, like Jasinowski, believed that the damaged tunica intima would lead to coagulation. He didn't have knowledge of the clotting cascade, but he thought that this was the barrier to the consistent success of their techniques. Histological studies of thrombosed vessels, as well as clinical observations made by surgeons like Virchow Triad, Paget, and Bulroff, improved the understanding of the thrombotic cascade and damage to the vessel. And by the end of the 19th century, it was understood that preservation of the endothelium was vitally important to preventing coagulation. This was further improved with the vascular work on physiology and thrombosis by Carrel and Guthrie. Now, Guthrie was actually a physiologist, not a surgeon, but was joined by Carrel in a number of experiments and demonstrating the technique of how to do an anastomosis. And this has been reported in the literature. They produced a book on it and described the Carrel technique, which is basically taking a circle and putting a stitch on each third at 120 degrees to form a triangle. You could then straighten the vessel and complete the anastomosis. Sad thing is that Carrel won the Nobel Prize in Medicine for this, but sadly did not recognize Guthrie's work in it. And there was a lot of, excuse the pun, bad blood. In 1915, Shelton Halsey of Richmond, Virginia, published a book, Surgery of the Blood and Blood Vessels. And once again, this dwelled on anastomotic techniques and how to stop hemorrhage. There was much debate at the time over whether intima should be included in the vascular repair or not. Most of them insisted on including the intima. A lot of work was done on dogs, and in 1906, Guthrie and Carrel gave an account of reimplantation of a dog's hind leg above the junction of the middle and lower thigh, with a technique that wasn't going to be used for another 53 years. You see, what held people back at that time was anticoagulation and heparin. Many attempts during the wars previous to that tried to fix vessels to no avail because the grafts were thrombosed. That was true in many of the battle injuries and very disappointing. It was only when heparin was described that the success of vascular anastomosis improved, and that was in 1916. And it was Gordon Murray who found that it could prevent thrombosis when performing an end-to-end anastomosis, and for the first time reported a success rate of limb salvage with battle injuries of 87%, compared to the 49% that occurred prior to ligation. Since then, we've been able to stitch smaller and smaller vessels for a combination of factors. One, the suture material itself, the proline, has got finer and finer, together with metals. That meant that the needle has got finer and finer. Then, of course, we had microvascular surgery, and it was felt for a long time that vessels below 3 millimeters in diameter could not be repaired because of the suture material and the thread. But as that got better, and the now use of microscopes, patency improved significantly. And the most striking example of this was reported from China in Xian and colleagues in Shanghai. And before the introduction of the operating microscope, their success rate in digital reimplantation, that's reimplanting fingers, was only 51%. And after the introduction of the operating microscope in 1973, this rose to 95%. So the principles of vascular anastomosis are good materials, lead, thread, needles, and cardiac surgeons now wear loops, that we need adequate exposure. We shouldn't let the vessel dry out. We need control, proximally and distally, then careful handling of the tissues. We've heard that before as well. And we've got to ensure that we have an adequate diameter so there's no stenosis in my joint. And the other important thing in this occasion, as I've got here demonstrated, my ring would be a suture is bring intima to intima on everting stitch. Because, as I noted, in many of the failures in vascular surgery, as soon as blood hits anything outside the intima, tissue factor is the most powerful stimulant for coagulation. So monofilament, non-absorbed suture, and full thickness suture. And small bites. I use 4O, and we're going to do this in anastomosis now with 4O. It's 4O, and I call it 4 by 4 by 4. 4 millimeters deep, 4 millimeters apart, 4 millimeters from the edge. And that's what I've used years for doing aortic repairs and vascular repairs. Now, the thing is, that's absolutely fine for stitching vessels. And you need a tension such that it's watertight, it doesn't cut out. Remembering again, if your thread is dragged through the vessel, that is an immediate feedback in a bleed or wet anastomosis. The challenge, therefore, especially described in aortic dissection, is ensuring that your needle is at 90 degrees to the tissue. And this is the first time that I actually noted this in the literature described by a surgeon. So I would start away from me. But here you can see, as in a dissection, the intima can be torn. I need to actually find a place. I'm going to come 4 millimeters and come there, and I'm going to make sure, gently hold the intima to place it and full thickness through both. And remember, as we said last time, there are two other important principles when doing a vascular anastomosis. One, downstream, and on this side, we're going to make this downstream. You've got to go from inside to out. Because if you don't go inside to out and bring the intima to the mucosa, it will be a source of dissection. So outside to inside, inside to out is what one needs to pay attention to all the time. So we'll take this through. And I'll probably you follow, please. And I'm going to come along, bring this down there. And now I'm going to stitch towards me across the posterior wall. But when I take up the tension of the suture, I'm going to make sure that I take up the tension of the suture from the outside, not from the inside, as I previously demonstrated. We'll just give you an idea, and I'm mindful of the time. I just wanted to give you an idea. So where am I? I again have to think on the outside. So I need to be outside to inside here. And the alignment of the suture is, I'm going to do this in two. Because the two edges are not sitting together. Inside And I'm not infrequently finding myself talking through an anastomosis, showing that I'm accurately placed. On the outside, I can take out the tension on that and how easy it is to lose your sutures at the moment. I've got where's my the end of the suture? There it is. Okay. And this is actually when you first start going on anastomosis, any anastomosis, the difficulty is orientating yourself and from the beginning. So again, I'm coming through, and I'm using a range of techniques of forehand and backhand. And with each stitch, focusing on the placement, I'm having to change my body position, change the angle of my needles with each and every stitch to ensure that I'm getting a position. I'm thinking to myself here, I should have had this down on a more substantial surface like a book, so it didn't move on the table. I'll remember it for next time. So what I'm trying to do here is take the suture in from outside, and my assistant is, without prompting, remembering the 2/5, 3/5 following and holding it in the direction and taking it to him, and he is maintaining the tension. When you're first starting off these anastomosis and get going, you'll find the posterior wall is the most awkward. It is the most awkward, but it also, in many circumstances, is the most important, because once it's done, particularly as the vessels are fixed in position, unlike the bowel, you will not be able to get to it again. So you'll find that many vascular surgeons, not that they're not paying attention at all stages of the anastomosis, but are paying particular attention to the posterior wall. And that is the wall that you'll never see again once you've done the anastomosis. So note that I'm doing this to the side because the intima in pink was not aligned properly. So my alignment now is my needle going through the adventitia and the intima, and hopefully pulling it. So if I pull this now, you will see that I'm now getting an intima to intima approximation now. And that will become better as I come around. The sock model, maybe I should have used a bigger needle rather than 4/0. So I'm finding the needle on the smaller side at the moment to get through the full thickness. I hope you can appreciate what I'm thinking about each time is the alignment of the needle. And you can also appreciate that it's not so easy in some circumstances to rotate the needle. And you do have to actively think about your position. I'm using my fingers on the vessel here. Your fingers actually are better than forceps. It said that forceps crushes tissues. And if you're dealing with thin tissues, use forceps. So the idea there, mindful of time as we're coming on, is what we want is intima to intima, as you see there. And it should be everting. It'll become easier from this side now. I can come over the top and towards me and join the two together. So to practice this 90 degrees, to practice this 90 degrees, we can go back to our banana model and take a needle and start thinking, how can we practice orientation? Take it off the white plate, because I'll demonstrate what I've done. I've cut a banana in half, and with a teaspoon, I've just scooped out the flesh. Now, what I want to do, and I can practice with these two halves, is take a needle through the tissue, and I'll take it through here. Start the one here. Okay. Take it through. Deliver it on a curve. Remember that it is not going to be forgiving for failure to deliver the curve. And the angle of the needle on the needle holder changes as I come around, because the displacement of my wrist from my elbow changes as well. So point, and I'm using the point to be deliberate to position and precision of my stitch. And because the banana goes brown, as we've demonstrated previously, we want to actually see that the rotation of our needle is clean in all these directions. So I cannot just drag it out at all. And it's a nice exercise to practice and get you thinking about how you use a needle and the placement. You're very welcome to answer questions as I continue a few more stitches here to demonstrate the principles. So any questions so far from anybody? Now, stitching veins, of course, is totally different kettle of fish altogether. In essence, you don't close veins with continuous sutures, because you think about it, what happens when the cardiac output increases? Your venous return needs to increase. And if your venous return increases, the vein has to expand. Okay? So if you've got a continuous, non-absorbable suture in a vein, you will actually cause a constriction. So all veins, all stages, need to be closed with interrupted sutures. Everting, of course, but interrupted nevertheless. If there's a problem with the diameter of the vessel, then it is better to spatulate it and stitch the two together, such the stoma, the mouth, is wider than the lumen, and you haven't got any constriction and flow. It's interesting that at one stage, there's another vascular book that actually focused purely on hemorrhoids, which is a totally different thing altogether. But you can see you can't rush this. You can't rush an anastomosis, and it has to be precise. And you have to adjust yourself and your needle angles so that you're pointing into the tissue. Because if I'm not pointing into the tissue on one side, or if I'm dragging it out of the tissue on one side, I will see skids. And skids means I have not rotated the needle. So I want to give time for discussion. I'm going to stop there, but I'm going to focus down on this and get you to have a look and judge yourself as an exercise. Okay? You can use the banana to see if you're 90 degrees across. Okay, so you're 90 degrees across, and are you equidistant from the edge? And every single stitch should be like that. Now, what's interesting, my colleague, Ashok, who unfortunately is no longer with us, he used to do a lot of work for the veterinary school. And he actually said, contrary to what we're teaching here, that regular even stitches on the aorta of a dog was not a good idea because it used to separate like a postage stamp and tear apart. And in that circumstance, in dogs alone, you want them at irregular distances from the edge to stop them tearing apart. But what was interesting in my thinking about instrument handling was literally brought into stark review when I'd stood opposite a trainee who did a beautiful aortic valve replacement. And his stitches on the aorta, like you've seen on the banana, were 4 by 4 by 4 and looked meticulous. The clamp wasn't off, but it looked beautiful, and his needle skills and accuracy were precise. The clamp came off, and it was fine for a minute. And then the aorta did this. Started separating like a postage stamp. I said, I'd better come round. And I came round, asked for a suture to start suturing it again, thinking, what on earth is going on? And I made a stitch. I rotated the needle through the tissue. Can anybody tell me what I felt? You're right. You're quite right. I didn't feel anything at all. My needle went through that tissue like a hot knife through butter. I took a slither of the aorta, and the histology confirmed my thinking. This man had severe cystic medial necrosis. He wasn't consented for a root replacement, so I buttressed this with Teflon on either side to hold the walls together. But I reflected on why this happened when it looked beautiful with 4 by 4 by 4 sutures. My conclusion is that my trainee was gripping the instrument and not holding it with a lightness of touch. So therefore, he could not feel the tissue as the instrument went through the aorta. And I found the same when the trainee was doing an aortic valve replacement. When you take the needle through the annulus of the aortic valve, the annulus should feel like a bit of shoe leather. That gives you, you've got a good bite. That patient went back for a paraprosthetic leak. And I have no doubt this is because the bite wasn't deep enough, because they didn't feel the tissue. And this comes back to what Lord Bartlett Monaghan says, is that a good surgeon should purposefully and deliberately move in their actions so as to and caress the tissues. And that is the work of an artist and not a mere human of flesh. So I'd welcome conversations, and my fellow sensei, Prof. Sile, is on the line, and she's an experienced obs and gynae surgeon. And last week, informed us that is responsible for restoring tubal integrity of fallopian tubes. And perhaps, Prof. Seeley, you can give us your insights into how you stitch fallopian tubes, because that is an anastomosis as well. Thank you.
Hello, Prof. Hello, Prof. Can you hear me?
Yes, thank you very much.
Yeah.
Thank you, Prof.
Okay, Prof. Actually, that's tubal fallopian tube. The fallopian tube is very, very dedicated structures in our body, and then also it is very important structures for the fertilization and reproduction. If you ask me, then I can tell you the truth. I have seen it. It is less than 5 in my life, I would say, because when I was like very early in my trainees life, and those days, like 40 years ago, there when not much of IVF in vitro fertilizations facilities. So like in those days, if they found that HSG and both tubes are blocked and were blocked, so it's like our professors, they decided to go for that. So they were trained, yeah, for that tubal anastomosis, yeah. So I have seen once, I remember it is like 40 years ago, then when I became OBGYN master trainee in University Malaya, and then of course, our professors, maybe 1 or 2, it's like in medicine, this kind of rare cases like see one, do one. Yeah, this kind of.
And what principles? Obviously, you've got to be accurate, but what are the principles of
Yes,
the muscle and the mucosa of the fallopian tube?
sure.
How do you join them together?
Sure, Prof. So because like if the tubal blockage and you have to cut off that that piece of the blockage and then make sure that both end has the proper lumen.
Yes.
The lumen, yeah, the intact lumen. So maybe a little bit like dilated on the fimbria end, and maybe smaller caliber in the proximal end and the distal end. The trick is that we put the stent in the small, it's like nasal tube, like the small tiny tubes. So we put the stent in, and then we want to make sure that this is patent, it's like not, our sutures not go through and through to the other side. Yes, yeah. Because we can't do from inside out, so we still have to do from outside in. So it's like from the outside, yes. Outside
is
in,
is it a 1-layer closure or 2 layers?
Oh, yes, Prof, because this is very dedicated tissue, so we can't do 2 layers, but with the 1 layer of continuous suture. But the stent was in. Yes, Prof, that is like Proline. Yes, yeah, but the smallest one.
The smallest Proline.
Yes, smallest Proline.
And of course, got to be careful not to make sure that you cause a constriction.
Yes, Prof. Yeah. All right. So I like your words that not too tight, not too loose.
So, okay, not too tight, not too loose. How do you determine that in your suture? Because many trainees will say, what do you mean not too tight, not too loose?
So if you can, sure. So if you can see the structures, it's like if you too pull, then your tissue will be shrink.
Yes.
Yes, yeah. Right. If you pull too tight, it will show. And or otherwise, if too loose, you can still see the thread, the loose thread. So again and again, the practice make perfect, and then also the experience tells. Yeah.
Yeah. So you're looking for subtle signs. Just imagine that you're bringing your fingers together.
Yes.
Start squeezing them like that. You can see my knuckles start blanching.
Sure.
I relax it. My knuckles are not blanching. So there, that's tight, that's not blanching. and you're almost seeing that change of color and pallor and the tissues itself. So you need to be careful. So any
Yes.
questions from our audience?
Can I add on one more
Of
issue?
course, please.
Yeah, sure.
Yes.
Because that's your lectures remind me my training days again when I was elective posting in a surgery posting. Then when I assisted the renal transplant, so the beauty of that renal transplant at the middle of the night for the life with a live donor, and yes, we assisted the arterial anastomosis, and then also the venous anastomosis. And then also
the ureter to the bladder.
Yes, uretary implantation.
So you've got 3 anastomosis there, 3
yes,
tubes.
Prof. Yes, Prof. Yeah, that is so much so dedicated. Yeah.
And a lot of different tissues. And it's the same, cardiac transplant, lung transplant. It's all the same, much the same.
Yeah, thank you, Prof. Yeah.
So
the instruments, Prof. The use of instruments, the right instrument, because if you use the smallest needle, and then we should have asked for the fine instrument as well. We always ask for the plastic sets, plastic surgery sets.
Indeed, you've got to have the right tools. I know surgeons should not blame the instruments, but just think of this analogy that you have different clubs when you go around a golf course to drive, to putt, to chip, etc. In the same way, you need different instruments for different tasks. And that's why you need to be familiar with the instruments, but on all principles, ensure that you hold them with the lightness of touch and maximize the pulp of the finger and the surface area of that with the instrument itself. I'd like to thank Dr. Apajita for the production this evening, and thank you very much for joining us. We have a feedback form in the chat room. Please submit your feedback. You will get your certificates for joining this evening. And next week, we're going to move on from stitching and focus on the scalpel. Thank you very much indeed, Dr. Apajita. Prof. Seeley, thank you very much indeed. And ladies and gentlemen, thanks for joining the Black Belt Academy.